am Dr.Parveen Bhatia from Institute of Minimal Access Metabolic and Bariatric Surgery, Sir Gangaram Hospital and Bhatia Global Hospital and Endo Surgery Institute. I am thankful to Clarinet for making me speak to our colleagues, the doctor colleagues, on the topic which is very dear to my heart. And the topic today will be super morbid obesity. Now, what is super morbid obesity? All of us have learnt about obesity. Most of us may be knowing about morbid obesity, but not many of us would be knowing what is super morbid obesity. This is based on BMI, body mass index. Normally, the body mass index of a healthy person would be 25, and if the morbid obesity is there, and if the BMI is more than 35 kilogram per meter square, it is called as morbid obesity. If the person is having associated disorders like diabetes, hypertension, thyroid, heart disease, joint pains, backache, infertility, and so on and so forth, and if the BMI is more than 32.5, and if the comorbidities are not there and BMI is more than 35, the patient is given the choice of obesity surgery, weight loss surgery, or bariatric surgery, or we call this as metabolic surgery. Now, what is super morbid obesity? Super morbid obesity is when the BMI, body mass index, is more than 50 kilogram per meter square. And believe me, there are patients in India, in Delhi, and all around who are having a weight of 280 kg, 290 kg, 300 kg, 350 kg. And frankly, we have been operating on these kind of patients with both laparoscopy as well as robotic surgery. But normally, if the person I would say person, not the patient, if he comes with a morbid obesity and he or she has a BMI of more than 50, that means super morbid obese, then they would ask me, what kind of surgery are you going to offer? Whether it is laparoscopic surgery or robotic surgery or open surgery. My answer is loud and clear: open surgery, no, 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 because of the complications of open surgery. Means complications would mean, for example, deep venous thrombosis, pneumonitis, incisional wound infections, incisional hernias, and so on and so forth. So open surgery for those kind of patients, big no. Now next comes the laparoscopic surgery. Yes, the super morbid obesity can be tackled with both laparoscopic surgery as well as robotic surgery. Laparoscopic surgery, the instruments are straight. For example, like this. The instruments are 34 centimeters, but they are straight kind of instruments. So it becomes challenging for the surgeon to operate on a patient of 50 BMI with the rigid instruments because of the torque of the abdominal wall. Because the abdominal wall is too deep in such kind of patients, so it becomes challenging to manipulate these kind of instruments, the rigid instruments of laparoscopic surgery, and definitely one is not able to give the best possible results with the laparoscopic surgery. For example, if we do sleeve gastrectomy or gastric bypass or mini gastric bypass, we may not be in a condition to do the suturing with the rigid instruments. And the next option is the robotic surgery. And in robotic surgery, we always have the stable platform. We don't have to depend on our camera persons, but the stability is given to us by the robot itself, one. Second thing is, it has got flexible kind of instrumentation. That means we are able to manipulate or maneuver the tissues and do the suturing just by sitting on the console, and then able to do the stapling, the suturing of the abdomen, of the stomach in sleeve gastrectomy or in gastric bypass. So the robotic surgery is the ultimate weapon, I would say, ultimate answer for the super morbid obesity. Now, many times, many doctors ask me, what are the indications and contraindications for surgery for super morbid obese patients? As I mentioned, that if the patient is having diabetes, hypertension, thyroid, sleep apnea syndrome, backache, joint pains, infertility, and so on and so forth, so many challenges can occur because of the morbid obesity, because of the super morbid obesity. So these ultimately are the indications for going in for surgery for morbid obesity, for super morbid obesity. Can these patients be tackled by medicines? Big no. They cannot, because we are expecting a weight loss of around 100 kg, maybe 120 kg, 130 kg. So there are no drugs which are available till date which can offer so much of weight loss. I know physicians, my physician friends would say that there are few drugs which came into market, but again they have been withdrawn because of the side effects which these drugs had. So we would not be in a position to tell you any medication which can lead on to 10, 20, 30, 40% of the excess weight loss. So there will not be any drugs. And what are the indications? If after getting a battery of investigations, right from hemoglobin to sleep apnea to pulmonary function test to stress echo and so on and so forth, if we find that patient is fit for general anesthesia, the patients are seen by our physicians, by our cardiologist, by endocrinologist, by nutritionist, by physiotherapist. So whole of the gamut of team members are there. So once they clear the patient for surgery, then we do the surgery either by, first choice is by robotic surgery, second choice is by laparoscopic surgery. And again, there are two kinds of operation. One is called as sleeve gastrectomy and another is called as gastric bypass. Especially for these population, super morbid obesity, more than 50 BMI is super obesity, more than 60 BMI is super morbid obesity, and more than 70 is triple morbid obesity. For those kind of situations, we feel that sleeve gastrectomy is the right answer, in which we take out the portion of the stomach and take it out of the body through the keyholes, and the stomach size decreases in size. The satiety of the fullness of the patient is there after he or she takes the meal, and that ultimately leads on to change in the weight, and patient starts dropping the weight by 5 kilogram to 10 kilogram in first week, 10 kilogram, 7 kilogram in next week, and so on and so forth. By 6 months, most of these patients have lost good amount of weight. So our thinking is that as physicians, we should be first aware that we should offer them the right answer, that you need intervention. You cannot sit on a time bomb and carry on thinking that if next wave of COVID arrives or next wave of some kind of viral infection is there, then you will be able to make through. I do not want to frighten any of my doctors or any of my uh, patients or people, but can you imagine, in last 3 years of COVID era, all of us have realized that the 64% of the patients who had died in totality all over the world, they were smokers. 74% were obese, and if you add 13% more, they were diabetic, 13% more if they were hypertensive. So what I mean to say, we should always tell our patients, please, even if you have to be afraid, then you should be afraid of the disease, and you should not be afraid of the operation. Operation is safe today because we get all the investigations and then we do the surgery. But whereas if we do not fear the disease, disease can carry on progressing, and that leads on to challenges later on. So my message to especially my physician friends is that please educate the patients, tell the people that there is no point in sitting on the weight, sitting on the time bomb, and ultimately having lot of comorbid conditions, as I mentioned, diabetes, heart disease, sleep apnea, joint pains, back aches, infertility, and so on and so forth. So it is a good thought that one should work on all the investigations. One should be afraid of the disease and its comorbidities, but we should not be afraid of the operation. I will be more than happy to answer any of my queries, any of the queries of any doctors on my mobile number 9810008507 or bhatiaglobal@gmail.com. Anytime you are more than welcome to ask me any questions about morbid obesity, super morbid obesity, super morbid obesity. Thank you very much. God bless you all.
Recording stopped.